So the purpose of this is just to show you guys just, the reasons why we put external ventricular drains in, and really just to discuss all the components of a standard external ventriculostomy and ICP setup. So we'll go through each piece bit by bit, and then we'll also go through some troubleshooting techniques and also how to set it up to transduce, and also we'll take some questions at the end. So first and foremost, why do we put external ventricular drains in? The primary reason for it is usually to reduce ICP through drainage of CSF. As you guys know, the skull is a fixed space that can only contain a fixed amount of components, whether it's really just three things. It's brain tissue, CSF, and blood. And any increase in any one of those elevates ICP. So the quickest way that we can relieve ICP is usually by removing one of those things, and that's CSF. So this is typically done as a bedside procedure, usually a life-saving procedure. In terms of infection risk, they've done a lot of studies and they've actually shown that whether it's at the bedside or in the OR, the infection risk is comparable. So in terms of getting things done quickly, it's better to do it at the bedside. So the way I set it up here is basically as if we've just completed the procedure. So this is how you guys are going to receive these patients, whether we finish them at the bedside, whether we put a ventriculostomy in the OR. It's not going to be exactly like this because we're using, obviously, test kits and everything. But this is going to be the general setup. So typically, the external ventricular drain will be tunneled out back through the back of the scalp, okay? And it'll be connected. It comes as two different components, right? So it comes as the catheter itself, okay? And then this setup from here down is the collection system. So those come as two separate things that usually the PA or the doctor will connect together. So this isn't the exact compatible thing, but I just taped it together to give you guys an idea. So as we're going to go through it, we'll basically go through everything in the direction of CSF flow, okay? So we have the catheter that's going into the brain. It's tunneled out through the scalp here, and our first connection is here. This is usually just done like through a screw top, basically. And we'll usually put a suture around it because this is a common place for things to get disconnected, okay? And I'm going to kind of come back to this as like part of your like hourly checks on these things. So our first component here is a three-way stopcock most proximal to the patient, okay? This is something that, you guys need to be aware that it's here, but it's not something that you're typically manipulating, okay? This is a common port that we use as PAs and doctors for troubleshooting usually, since it's the most proximal or closest to the brain. Whether there's a clog here from some debris or anything, we typically will work through this port. This is not something that you guys will typically do. But you need to be aware that it is a potential area for trouble and whatnot. So it's a three-way stopcock, okay? Pointing up means everything is open to flow, okay? So obviously with the stopcock up, everything's open here, okay? And we'll get back to why this particular connection is important when we kind of rally back to go through all the troubleshooting techniques. So not much to worry about for you guys in terms of this particular component here, but obviously you need to be aware that this is one spot. When we talk about clamping drains and everything like that, you'll hear us talk about this, quite a bit. It's probably because back in the day, before they had all these fancy setups and stopcocks, when a neurosurgeon probably asked a nurse or somebody else to clamp the drain, they probably literally came here with a clamp and closed the drain off. But when we talk about clamping, if you would to turn this stopcock in either direction, it would stop the flow of CSF. Okay, so we always want to, in this particular instance, for this port, we always want to leave this open. Okay. The next component we have here is a little CSF access port. Again, this is like more of just like the provider, like PA, MD hub. This is just a lure lock where you can take CSF samples from. You can also use it as an area to flush the drain as needed. Traditionally we used to use this a lot, but the more and more, especially at Lenox Hill and other places that we used this port a lot, if we tried to draw CSF off of this, it could sometimes cause problems in terms of you know, the ventricles collapsing on itself and the drain being clogged and not working. So we don't typically use this anymore. So we typically just kind of leave this be, leave it alone. Now you have the CSF highway coming on here. But a particular important thing that I want you guys to all be aware of, and I'm just going to grab some tape right here.
Can I ask a question?
Yeah.
On that cord that you were just talking about, would we put one of our chlorhexidine?
You can actually. That's actually a very good point. Yeah, just to keep it kind of like secure and off and everything. That's a very good point. Yeah, one of your, it's like an orange or green cap that it is. Yeah, that's a very good point. Yeah, I would recommend that. So one thing I like to do, if we got our head here, we can just imagine that we have a patient's shoulder here. What I typically like to do is to put a piece of tape kind of where the drain comes around onto the shoulder. The reason for that is when you guys are turning patients, transporting patients, anything like that, any tension on this, if you pull, it can pull the drain out. But, and it's such a simple thing to do, if you are to put just a piece of tape, and you can again put it here, like, you know, in between the two ports, even here. You know, if you start pulling on this here, it pulls here and it doesn't tug on the actual catheter itself. We do things on the scalp to make sure that if it does get pulled, it stays. You know, we suture the drain, we put some staples there and everything to make sure that if it does get pulled, it doesn't get pulled out. But if you ever see that there's no piece of tape here, just put a piece of tape, you know, tape the drain to the patient's shoulder, just so if there is any tension, it doesn't pull on the catheter itself. So we're going to come along here now, and let me just move this to where y'all can see it, actually. So we come along, all the tubing, and this is about where 90 to 95% of everything that we do with the drain happens, okay? So again, a three-way stopcock, as you guys can see. It's in the open position right now. Okay, and we're all going to develop good habits here together. So whenever we talk about clamping and unclamping the drain, this is the stopcock that we're predominantly talking about, not the one up here. This is where we want you to work. And the reason why we want to do this is because we want everyone to be standardized, working on the same area. So if one nurse thinks that clamping it is up here and the other one is clamping it down here, it just creates a little bit of confusion. So when we're talking about things like this, I just want you guys to focus on what's going on over here. So CSF will come through. It's in the open position right now. If we were to clamp it, we would just turn this stopcock in the up position. Now, why the up position and not the down position? It's going to make a little bit more sense when we attach the transducer in a little bit, okay? So again, this is going to be the primary area of focus, okay, for us when we're transducing ICP, clamping and unclamping the drain. So while we're here, we can level the drain now, okay? So each EVD collection kit comes with this high-tech level here, as you can see. There actually is a higher tech one. In one of the kits that we had, there was a laser level in it, actually. But this is the standard one in which it comes in. It's basically just a rope and a carpenter's level attached to it, okay? So we talk about neuro height. Head of bed should always be 30 degrees, 15 to 30, but 30 is more optimal to facilitate, obviously, venous drainage and CSF drainage, okay? So there's two ends to this, okay? There's this white kind of cap right here. And if you look at this piece, if you look directly in the back of it, there's a little hole here, okay? And this hole matches up exactly with this stopcock here. So this little white tab, okay, is going to click into the back of this, and you'll hear it click just like that, okay? And then what you want to do here now is string this out, obviously as far as possible as you can, and you want to line it up with the patient's, you know, get it as taut as you can, and line it up with the patient's tragus, okay? Now, why the patient's tragus? The tragus anatomically lines up with an area in the ventricular system known as the foramen of Monroe. It's where the two lateral ventricles, we put the EVD into one of the lateral ventricles, it's where the two lateral ventricles connect with the third ventricle. So it kind of serves as the centerpiece and the connection of both sides of the ventricular system. So it kind of gives, it's basically the center of the ventricular system. So we don't just do the tragus because it's a nice little thing that we like to play with. No, it actually serves a purpose here. So we stretch it out as much as we can. As you can see, our drain is a little too high. So you would level it to the point where this level gets level. And you'll have to excuse my... Obviously, it's a little better with two hands. And it doesn't have to be exact to the millimeter, obviously. You want it as close as possible. But this is the purpose of all this. So once we get it kind of taut enough, okay. They made a little fancy hook on the back too, so you can always take the ring here and put it on there. Okay. So now we've got it level. Okay. The tubing's going to come up into the collection chamber here. Before we get to the collection chamber, okay, you'll see a red line right here and a bunch of set of numbers here. And this is there's one side that's millimeters of mercury, and the other side is centimeters of water. So we want to focus on centimeters of water, which is the black portion of the meter here. Okay. So what does this mean? So a typical normal ICP is anywhere from 0 to 20. Okay. So we want to set the drain at a level that's going to facilitate drainage because of ICP. So it's a closed system. So just like anything else in the universe, everything flows from high pressure to low pressure, okay? So, as you can see here, okay, it's set at 12. If I were to set it to 10, okay, that means anytime the patient has ICP in the brain greater than 10, right, where our setting here is 10, it's going to push fluid into the chamber here. So that's the reason for that. We usually start off, depending on the pathology, we typically start off at 10 because that's like the isometric number for ICP. Again, depending on the pathology, we may set it a little lower. We may set it at 5 if we want more aggressive drainage. But that's the significance of this number, okay? All right, so if I were to set it to 20, which is the high end of normal, which is typically what we would do if we were weaning patients off the drain. So basically, anytime a patient has an ICP greater than 20, it would drain. So that's the purpose of this right here. And for this, you just squeeze these little tabs right here, and you can move it up and down as you see here. Okay. So we'll set it at 10. He's level. Okay. So this, as you can see, this meter here is slightly above the level of 0 right here. So it's set at a higher pressure, basically. So we come to our collection chamber here. As you can see, it can hold up to 75, 80 cc's. We hope nobody drains that in an hour. Collection chamber here. And this, when the drain is in its open position, anytime there's a higher pressure, the CSF is going to drain into the chamber here, okay? And the next part you're going to see here is the stopcock. Again, this is a three-way stopcock as well. In order for it to collect, you obviously want the off part of the tab in the up position so it collects, obviously, okay? All right. Every hour when you come in to assess how much it's drained, you want to empty it into the bag. So for that, you just turn it 90 degrees, and then whatever you have there for the hour will empty into the bag, okay? Sometimes if you have a fresh system in a fresh bag and this bag is nice and collapsed, it may not drain right away. Sometimes you need to take the two ends of the bag and kind of open them up to allow it to go. So this is only used for when you're emptying the chamber of CSF, okay? Now if we have a patient here long enough where we need to replace the bag because it overfills, okay, this is connected here and this should usually be done in a sterile fashion. Okay, we do have replacement bags here, but say it's 700 cc's of fluid. Patient's been here for 4 or 5 days, drained CSF, and again, you can pretend that I have sterile gloves on. It's not a totally sterile procedure, obviously, because you need to touch the cap here, but it should be done as clean as possible. You would just disconnect here, okay? Eventually it'll come off. Sometimes you need to take these little tabs off, and there it goes, okay? And this comes with a little cap attached to it, and you would just cap it, pull it off, and then discard it, okay? So we can pretend this is the new bag. I like to connect it first, okay? And again, you would usually, chlorhexidine this and everything. It usually doesn't come with the cap on, but then you're ready to go, basically. So our system is open, it's draining. The other part of it that could help you guys is that there's a little kind of clamp here, as you can see, that opens up like this. If you don't want this kind of hanging all willy-nilly in the air, once you get it leveled and everything, I'm going to be a little higher, but you can attach it to the back of a pole here by just moving this clamp right here. And then it also has these white tabs on it for extra security. So that's the basic components of everything we're dealing with. So once we get everything set up, okay, we want to attach the ICP transducer. Okay. Just for the sake of the demo, we'll leave this just as it is right now. Okay. Alright. We'll pretend that it's level here. So your standard ICP, arterial monitor transducer kit. Okay. We're going to waste about 75% of this. So you don't need any pressure bags or anything of that sort, okay? So I'll kind of pull it out in the front here. So once you undo everything, hold on to these dead end caps, because we're going to need those in a little bit. Okay. So you are basically going to take off everything, okay? So the front part of it you're going to remove. That gets wasted over there too. And the back part you're going to remove. Sometimes you need a clamp to get them off, but so this is basically going to be your setup here. Always change these caps out, okay? Because I don't know if this one that they give you is it dead end or not. No, it's open, so you have to change these out, okay? All right. Comes with two caps, so you're going to put one cap on the top here and one cap on the back here, okay? So now the system is completely closed, right? So typically when we get the EVD in the kit, okay, this will have a cap on it as well, okay? So you'd have to take, this is where we're going to attach the transducer right here, right? Okay, that's obviously the center of our system. This is where all of our focus and all of our work is going to be. So this is how you're going to have it ready to go and ready to attach. Okay. Now it's very important that you keep the stopcock in this position when you do this step. The reason for this being is if you have it like this, okay, with the drain clamped, the second you take this cap off here, you're going to have CSF come and spill out here. Which is a no-no, right? Because once the system is closed, we want to keep it closed, right? So it's very important when you do this step that this is in the off position. Otherwise, you're going to get CSF all over the floor, okay? So you simply just attach it, okay? And that's it. You have the rest of your transducer here. You connect it. And then after you zero it and do everything else you normally do, probably better than I do, you'll get a waveform. It'll look similar to your pulse ox and arterial waveforms. So that's the components of it. That's how to set up the ICP. Most important parts, obviously, with this step are these caps, because if they are open caps, you're going to get fluid backing out of it and everything like that, and it exposes it to the environment, which is obviously a risk for meningitis and whatnot. The reason why I had mentioned that we only want to clamp this in the up position, okay? Because when you're transducing ICP, okay, if you were to put this in the down position, because of the way the CSF travels, you're actually blocking off, you're closing this part. It's like a little nuance, where you're turning the drain off to where the patient's, to the brain basically, okay? By clamping it in the up position, you're actually keeping it open in a sense to the brain, and that's why you're able to transduce the pressure here this way. So when we just get into the habit of clamping it in the upward position, turning it off in the upward position, okay? Again, it's a little nuance, but that's what happens.
So Nick, that's,
yeah.
sorry, just quick. So the transducer, that's where we're leveling.
Correct. Yes. Sure correct. This is where it should be leveled with the tragus. Correct. Correct.
And the transducer, it's just full of air. You're not priming it.
Nope. You don't prime it. You just pop it on, and that's it. Okay. The reason being, though, is the reason why we want these to be the dead end, or I think, is it vented or non-vented? What do they consider these to be?
No, they're not vented.
Not vented, right? Okay. Is because if you had vented caps, you could get fluid out and it could push out. We've seen that a bunch of times before too. Okay.
How often are you
So what is part of your hourly assessment? Okay, so every hour, okay, we need to measure how much CSF has been drained, okay? We need to measure ICP, okay? And there has to be a neuro check that goes with it. Those are the three prime things, okay? I also want you guys to get in the habit, and it doesn't have to be microscopic with a magnifying glass checking every single piece, but just do a general survey of all the pieces of the drain. Why do I say this, okay? 2 or 3 years ago, there was a company, okay? Can't even remember what company it is, so lucky them, that there was a big recall and a lot of malfunctions where pieces were just breaking off left and right. And the slightest turn of a stopcock or anything else, pieces would just snap off. And the whole system would be open, people were leaking CSF, and it was sometimes happening like randomly without people even in the room, okay? So we don't use that particular system anymore. Before that, when I first was a PA 10 plus years ago, there was another company where the tubing was just leaking. Like, I don't know, it was the way it was manufactured or something of that sort. So this is my own neuroses, like just do a general survey of the drain and all the components, just make sure everything is intact, make sure nothing is leaking, okay? So every hour, okay, you should check to make sure the drain is level, obviously. You count how much CSF is in the chamber, okay, and every hour you would come, empty it into the collection bag, and then close it back off so it's ready for collection again. And then every hour again, you would clamp the drain and check your ICP, okay? All right? When do you call us, okay? If you get drainage of CSF more than 20 cc's, you give us a call. The reason for that is because the average human produces about 20 cc's of CSF every hour, okay? If there's consistent drainage over 20 cc's, okay, patient can overdrain and have complications. And typically the complication with that is a subdural hematoma, okay? It is hard to do with an EVD, okay? It's more common with lumbar drains, but it has happened. So 20 cc's is the magic number in terms of CSF drainage, okay? What would we ask you to do, okay, if it drained over 20 cc's? If it's 21, 22, we may just say, okay, leave it. But if you get 22, 23, 24 cc's in consecutive hours, what we may ask you to do is to just clamp the drain for an hour, okay, just to slow the drainage down, okay? If it's a condition, if you guys remember the patient that we had, like the intracerebral hemorrhage that had a lot of thick clotted blood, if you keep the drain clamped for an hour, all that blood that was in the tubing is probably going to clot off and the drain's going to stop working. So sometimes what we might ask you to do, and obviously like we'll swing by and double check all this, but just raise the level of the drain. Okay, so it drains. It's still open, but it'll maybe be drained a little bit less. Okay, I wouldn't probably ask you to put it that high, but that's probably what we would do. If it drains 0 cc's, okay, which could certainly happen. Okay, either it's not an ICP prop. There could be one of two things. Patient just doesn't need to drain CSF for that hour. His ICP is not that high, or the drain could be malfunctioning. Okay, so if you get a 0 output on an EVD, it's important to let us know. So how do you know if the drain is working or not, if there's 0 output? Okay, very simple test. Okay, and once you have everything all set up, okay, it's easier to do it this way than take the drain off the tower completely. What you would do is you would just, again, pinch the tabs here and just lower the drain to its lowest possible setting. Okay. If the drain is working, when you lower it all the way down, you should see some drops and some drips of CSF going to the chamber. Okay. If you don't see it, okay, the drain may be malfunctioning, and that's an important time to call us. Okay. The other way to test it, which I don't think with this particular system is as reliable. Conversely, if you were to raise the drain as high as you could, you would see a backflow of CSF out of the tube. And so that means that there's a connection between the two. Because not only does this run, this whole system run on pressure, but it also runs by gravity as well. So if I were to take this, right? If I were to take this and just, and this is why I say it's easier to just kind of raise and lower the drain. If I were to take this and drop this on the floor, basically, because it also runs by gravity, CSF would come shooting out of the patient's head, basically. If I were to raise it all the way up here, CSF would go all the way back into the patient's head, basically. Okay. So it runs by pressure, but it also runs by gravity as well. Any questions about that? That was the drainage component of it. What else do you call us for? When you come to transduce the ICP, okay, if the patient has a sustained ICP greater than 20, when they're not being stimulated or anything like that, you call us, okay? The reason being is because, you know, if the patient is, oh, this got disconnected. The reason being is, you know, if the patient's just, you know, sedated, resting calmly, and the ICP is 20, 30, that's concerning. But if you go to transduce an ICP and they're thrashing, and you know, this happens, right? And they're thrashing and everything like that, it's going to be not a reliable ICP. So I like to say, you know, clamp the drain, watch the monitor for a minute or two. If they're resting comfortably and their ICP is 25 or 30, that's like a pathologic ICP measure, basically. So anything above 20 sustained while the patient's not being stimulated. Okay. Questions on that? Okay. Any change in the characteristics of the CSF, right? If the patient's been draining clear CSF all day, okay. Anytime you're repositioning the patient, okay, laying them flat to change them, turn them, anything, you clamp the drain, okay? It's got to be off, okay? Because if you drop the head, you know, or anything like that, changing the position is going to affect this, okay? So you keep it clamped for, you know, the 15, 20 minutes. You have to do what you have to do, and then you re-level it, and then you reopen it back up. Suctioning, okay, another thing that you clamp the drain for, okay? It's sometimes hard to remember this, but I can't tell you how many times, like, patient's plugged or something like that, you're aggressively suctioning them, and then you look in this chamber and there's 50, 60 cc's of CSF. It's because all that, you know, coughing raises ICP and everything, and they're going to drain off, okay? So keep that also in the back of your mind. And also transport, okay? It's got to be clamped during transport as well. I like to take it off, everything off, and then I usually put it on the patient's, what happened here? I usually put it on the patient's belly or something like that, just to keep it on him. I don't like to put it on like the pole on the back of the bed because the bed swings, you hit an elevator door and everything, the whole thing breaks off, and that's a problem.
When you say to clamp,
The reason why I don't want you guys clamping it here is because there's been many a times in my life, Nancy's probably experienced the same thing, where you get a covering nurse and you guys are clamping it in different scenarios, which is like in different positions, which is why I only want you guys to clamp it here, where a nurse comes in to cover, clamps it here because they went into suction the patient or whatever, right? Forgets to unclamp it, and then an hour or two goes by, you call me and say, I have, the drain's not working, right? And then I come in and it's, because it's clamped here, and now, it's not the end of the world, but it just creates a lot of anxiety and frustration, which is why I just want you guys to get in the habit of just focusing your attention here, okay? Everything we do is for a reason, right? Because something bad has happened before, right? So it's that's the reason for that. Why this is really just for the MPs and the PAs to kind of deal with here. Yeah, I think that's about it, guys. Questions?
Question. You spoke before about weaning the drain off.
Yeah.
I guess it depends on the patient, but
Mhm.
the change in interval,
Yeah.
like of the
How would we typically
height.
do it?
Yeah, what's
Yeah.
the increment?
There's no every doctor has their own and style and techniques. I've been with doctors before where if it's at 0, where is it? If it's at 0, one day they'll be like, okay, raise it to 5 the next day, see how the patient does. Raise it to 10 the next day, see how the patient does. Raise it to 15 the next day, see how they do it. Then 20, and then they'll just clamp it for 2 or 3 days. So it's like a week, right? Just a little long. So there are other doctors that'll be just raise it to 20, and if they're doing fine after 5-6 hours, just clamp it and see how they do. And usually if it's clamped for 24, 48 hours, we usually follow it up. We usually do a CAT scan before we clamp it, and then a CAT scan after, when they've been clamped for a day or so. Okay. I don't know particularly yet how Dr. Silva likes to wean his drains, but when we're weaning the drain and we have it clamped at all times, basically, we're continuously transducing an ICP, right? So during that time, there's no drainage of CSF. We're really just monitoring the patient's ICP, and at that time, we're looking at numbers to make sure they're not having ICP spikes, but we're also checking the patient. Do they have, depending on the level of consciousness and everything like that, do they have worse headaches? Do they have a worsening neuro exam? Are they more lethargic? These are kind of the factors that we take into account. Should this be converted to a shunt, or can we just take it out? But it's usually a CAT scan involved too. EVD set at 10 centimeters of water, okay, or 15 or 20, whatever it is. Transducer level with patient's tragus, head of bed 30 degrees. Monitor CSF output and ICP Q1 hour. Notify neurosurgery for sustained ICP greater than 20. Notify neurosurgery for CSF output 0 or greater than 20, basically. And clamp drain for positioning, suctioning, and transport. That's basically what the standard EVD order will look like.
do you still want to be called if, let's say you go?
I want you to call me for everything.
For everything.
Everything.
You're gonna regret that.
What's that?
So, if you have a big jump, if you have a big jump,
Yeah.
from 10, and then the next hour is 20 or something.
Yeah. If it's more of if you're noticing a trend, basically. If they've been ICPs hovering in the 5, 6s, and then for the next few hours they're 15, 16, that's a good point. If you're noticing an upward trend, if it's a single solitary spike, then probably not. And the patient looks okay. It's always about how the patient really looks, right? So they can have ICPs of 18, 19, and be totally fine, no headaches, no nothing. Neuro patients are funny, right? They do weird things. So.
And then also you